بسم الله الرحمن الرحيم. أبنائي طلبة سنة ثالثة كلية الطب جامعة الأزهر، السلام عليكم ورحمة الله وبركاته. اليوم هنبدأ نتكلم. هذه المحاضرة الثانية لنا طبعا. والمحاضرة الأولى كانت very basic وintroductory علشان to go ahead في الاناتومي في in the renal system. هناخد التوبكس organ by organ more or less على اساس تكون برضو in details، وناخد كلها بالريجنال اناتومي والكلينيكال اناتومي radiological anatomy microanatomy all the details we need what is meant by anatomy نتكلم. اضافة لايش؟ اضافة للكلينيكال related hence whenever we are coming across a certain organ or knowledge علشان at the end we need to practice medicine later on a proper basis. طبعا زي ما بنبدا احنا دايما في معلومات الاناتومي او في محاضراتنا للاناتومي نعرف الفانكشن اوف ذا اورجان we are going to study. يمكن functions of the kidney ذكرناها في المحاضره السابقه، لكن بهمنا just to recall it again. يمكن اهم function للكدني اللي هو اليورين formation. احنا عارفين الكدني is essential to our body. If we are having renal failure there must be some sort of renal replacement therapy. واحنا يمكن اتكلمنا على renal replacement therapy in the form of يا إما some sort of dialysis whether a peritoneal or hemodialysis or the current choice of kidney transplant. هذه أهم وبالتالي في عنا يعني الهيمودياليسيس البريتونيال دياليسيس بيسميها الهيمودياليسيس تحديدا بيسميها الكلية الصناعية، وهذه موجودة وبترتب whenever we are going to hospitals. نمرة 2 regulation of the blood volume of the body, mainly the extracellular one, and the exchange of substances, ions between the cells and to get rid and to secrete some of them through the nephron. The functioning unit of the kidney is the nephron. والكدنس تبعتنا زي ما احنا عارفين فيها 2 مليون نيفرون. Regulation of the electrolyte content of the body, just water and electrolyte imbalance. Just to go, this is one of the very important essential function, homeostatic function of the kidney is water and electrolyte balancing. Coming to the acid-base balance, pH of the blood, and of course the blood to do for the cells to do their main vital functions, very important and essential homeostatic function. Number 3 is the regulation of sometimes as we mentioned before, the blood pressure and the extracellular volume through the renin-angiotensin secreting system, what is known as the juxtaglomerular apparatus. This is in physiology, we are to talk about it elaborately really. Another hormonal function of the kidney is the erythropoietin manufacturing of the RBCs to the kidney. The patients with renal failure, we know, ultimately they will go in anemia because no cells to secrete or proper functioning cells to secrete erythropoietin, in addition to elimination of toxic and metabolites of second outcome of the metabolism hazardous to the body. Let us come to the regional position or the regional anatomy of the kidney. As we know, let us have a look on this diagram, really, on this very illustrated one. Come to the kidneys. We are having 2 kidneys in here. We are having 2 ureters. Again, I am repeating really. We are having the urinary bladder. We are having the urethra. The kidney is completely retroperitoneal structure. Just on its upper pole, there is the suprarenal gland. As we said, it is more or less pyramidal on the right side, crescent on the right side, and pyramidal on the left side. The right kidney is a little bit lower in position than the left kidney. Both renal arteries are jumping from the aorta at level 2, lumbar 2. Both kidneys having renal vein which is draining into the inferior vena cava. Those are the essential or gross structures, big structures of the kidney. But let us come to the description of the kidney itself. It's reddish brown in color and lined retroperitoneally on the posterior abdominal wall. واحنا عرفنا posterior abdominal wall. في عندي psoas major muscles, psoas major وminor. في عندي quadratus lumborum. في عندي transversus abdominis muscle. Very essential, protected. The kidney is well protected by the muscular, very strong muscles and the lower ribs from above. 12th rib on the right side, 11th and the 12th on the left side. Very well protected. And the bone just in the nearby. But sometimes the kidney could have some, if it is exposed to some trauma or something like it could be crushed against the spinal cord, the bone structure just in the midline. So retroperitoneally, resting on the posterior abdominal wall on either side of the vertebral column, and they are largely under the cover of costal margin, so it's well protected. The right kidney lies lower, as we mentioned before. Both kidneys could move downwards in a vertical direction during inspiration and deep inspiration, I mean, to about 1 inch, 2.5 centimeters lower down. And there is something on the medial side. From now, I like to talk about it really. Yes, this is the medial border of the kidney. It is a crescent in shape, or concave in shape, I mean, and medial border and lateral border. The medial border is just in the middle, nearly the middle of the kidney. There is the hilus or the hilum of the kidney. It lies on the medial concave border of the kidney. Each kidney has a vertical slit, as if the kidney substance has if it slit medially, that bounded by thick lips of renal tissues or substance. It extends into a large cavity known the renal sinus. Renal sinus. Okay. The hilum transmits the big structures, and if we are to just recall them from posteriorly, in front we are having the renal vein, then the renal artery, then the renal pelvis. The branch of the renal artery could be situated posteriorly, still in there. But anteroposteriorly, we're having the renal vein, then the renal artery, then the ureter or the renal pelvis. Let me express it this way. By the way, the renal pelvis could be intrarenal mostly, and ureter just coming out, or the renal pelvis could be extrarenal, as if coming from the hilus to and form it outside so as to do its function in a good way. The lymphatics and the lymph nodes and the lymph fibers are in the hilum, and those are very important just to look at and to know if we are dealing with some neoplastic lesion in the kidney. So the kidney is a retroperitoneal structure having good relations with the suprarenal gland, and it is bounded by musculoskeletal skeleton, let me say that, strong muscles, and posteriorly and medially is the vertebral column. Here is lumbar 2, where the big vessels are coming in and out of the column. In is the artery and out is the vein together with the ureter out, of course. Just to recall the anatomical configuration of the kidney, let us enumerate it by the figure of 2. We are having two surfaces, anterior to one anterior or anteromedial surface, and posterolateral surface or anterior and posterior surfaces of the kidney. We are having two borders. Exactly as I said, medial border and lateral border. Nearly at the middle of the medial border, concave one, is the hilum of the kidney. We are having two poles of the kidney, the upper pole or the superior pole of the kidney, and we are having the lower pole of the kidney. Okay. Now let us come to a very important point, coverings of the kidney, because those coverings of the kidney are helping in protecting the kidney and and limit the mobility of the kidney in its region, really. We're having four capsules of the kidney. The first layer is the fibrous capsule just on the substance of the kidney. This is the false capsule of the fibrous capsule. Fibrous capsule of the kidney, fibrous capsule of the kidney, you know, which is just in intimate contact with the substance of the kidney. From upper pole to lower pole, going to the sinuses in here. Yeah, the hilum of the kidney. Then the perirenal fat, this yellowish fat, just next to the capsule or fibrous capsule, we're having the perirenal fat, and this covers the fibrous capsule externally. Coming more as a third layer or third fascia is the gerota fascia. This is the greenish line, just from all around the kidney. This is the renal fascia or gerota fascia. This is a condensation of connective tissue that lies outside the perirenal fat and encloses both, very important point here. You enclose both the kidney and the suprarenal gland in one plane. It is continuous laterally with the fascia transversalis. Look at it, fascia transversalis coming in here. And this must give a very good point to fix, more or less, to stabilize the kidney in its position. Fascia transversalis is covering all, the abdominal viscera, Then coming the last layer is the pararenal fat. This lies external to the renal fascia and is often in large quantity, giving, as a cushion to the kidney in position. So as you know, if it is mobilized a little bit up and down, even vertically, as we have mentioned, or exposed to a trauma or something like that, it will be like a cushion protecting the kidney forms part of the retroperitoneal fat, like any other organs. The renal fat, renal fascia, and pararenal fascia, four layers support the kidney and hold them in position on the posterior abdominal wall. It's very important. Now look at the kidney again in here. This is the hilum of the kidney. This is the renal pelvis. This is the ureter. This is the upper pole. This is the lower pole. This is lateral border. This is, yeah, it's good to have this presentation in your mind. Of course, if we are to look at the kidney again, here is the cortex and the cortical slits coming in here. Cortical tissues in between the pyramids of the medulla. And those are the minor calyceal system formed by the various minor calyceal system, 2 or 3 major calyceal systems, really. This is a major and this is a major and forming one, they are forming ultimately renal pelvis to come and to give us the ureter coming out of the kidney. If we are coming to the renal structure a little bit microscopically, which is very essential and important, each kidney, microanatomy you could call it. Look at the kidney here. We are having two main structures. We are having a cortex in here, and we are having the medulla in here. Okay, the cortex, just keep in mind, it having all the glomeruli, but the tubules are coming in and out of the medulla, forming the pyramids. And the tip of each pyramid is forming the minor calyceal system. Minor calyceal, another minor making the one of the major calyceal systems. Okay, so the medulla is composed of a dozen of renal pyramids. Dozen about 12, about 11, about 13, 14, or about 12, a dozen of renal pyramids, each having its base towards the cortex. This is the renal pyramid, and this is the base towards the cortex. This is the renal pyramid, base towards the cortex. The apex, the renal papilla, or the apex, or we are calling the renal papilla, projecting middle. There are some diseases coming to the renal papilla, and is specifically been affected. Then coming to the cortex, this is the cortex between the medulla and the renal capsule, fibrous renal capsule. The cortex extends into the medulla between adjacent pyramids extending to the medulla. Yes, it is the outer layer, but it gives some of its cortical tissues in the as the renal columns we call it. And renal columns are in between the renal pyramids. As if dividing the renal medulla into its pyramids, extending from the base renal. This is the one renal column. Those are the renal columns from the cortex. This is the cortex, and this is the renal, columns extending from the base of the renal pyramids into the cortex and striations known as the medullary rays. Medullary rays. Medullary rays. Okay. The renal sinus, which is the space between the hilum, the renal sinus, which is the space between the hilum and contains the upper expanded end of the ureter, the renal pelvis. We showed in the previous slide. The renal pelvis is surrounded by 2 or 3 major calyceal systems, each of which forms 2 or 3 minor calyceal systems, calyces. Let us come to the relations. This is the way to study anatomy of bone structure. Let us come and concentrate on the relations. Before going to the relations, let us look at this coronal section in the body. As if we remove the skin, anterior abdominal wall, muscles, and the skin. And this is the transverse colon. This is the right hepatic flexure. This is the left hepatic flexure. Here is the pancreas. Here, the left kidney, upper pole of the left kidney. This is the left suprarenal gland. The right kidney is here, just opposing it a little bit lower. This is the right kidney, the upper pole, the anterior surface. And it has an intimate relations here. But let us complete this diagram because good to keep this diagram in mind. Abdomen is divided into infracolic compartment and supracolic compartment in relation to the transverse column. Here we are discussing the thing as if we are in the supracolic one, but we could elevate the mesentery of the transverse colon or mesocolon, and we can see the kidney through that place, through that area. We can expose the kidney. So the kidney here, this is the right kidney, and this is the left kidney, and this is the black lines. This is the stomach, anterior wall of the stomach. But the kidney is having relations to the posterior wall of the stomach, and this is the duodenum. This is the stomach, and give here is the pylorus. Then starting is the duodenum. So we have the duodenum is having intimate relations to the kidney, to the right kidney. Okay. Now, if we are coming to the relations of the kidney itself, that is the grammatic representative diagram, we are having here the right suprarenal gland in it, more or less pyramidal in shape, triangular in top view topography. Okay, this is the suprarenal on the upper pole of the left kidney, as if being directed medially more. Here we are having number 2 is the liver. And the relation of this right kidney to the liver is very important. Yes, we are saying the liver is an anterior relation to the anterior surface of the liver, covering anteriorly, and there is a recess between the anterior surface of the liver, the superior pole of the liver, and the inferior surface of the liver here. This space, we are calling very important anatomical fossa or recess, we can say it. We are calling this subhepatic pouch, or hepatorenal pouch. Hepatorenal pouch or Morrison's pouch, I'm saying it. Very important from the surgical point of view. It's a site of collections of fluids, of blood, of bile, of pus, this is very important. The subhepatic pouch, hepatorenal pouch. This is the area where the liver being covering the anterior surface and superior pole of the liver. Very important, really, of the kidney. Then number two, what is coming anteriorly to the anterior surface of the kidney is the second part of the duodenum. Then we are having here is the right colonic flexure where the transverse colon starts. Here ascending colon, right colonic flexure in here. So those are the anterior relations of the kidney. So right suprarenal, this is the diaphragmatic representation. Here is the blue one is the liver. Coming here is the colon, right hepatic flexure. And here duodenum is anteriorly near the hilus of this kidney and the ureter is coming out. Very important to imagine, keep this picture in mind. And this is the stomach. It doesn't have direct relations to the right kidney, but the duodenum coming out of the pylorus. But on the left kidney there is. Now, posterior relations of the kidney. Kidney is situated, as we mentioned, on strong muscles, and medially relations is the vertebral column. So before that is the kidney. This is the dotted lines. Those are the dotted lines. The dotted lines. Those are the dots. Huh? This is configuration of the that's the left kidney, and this is the configuration of the right kidney. And the kidney here is situated posteriorly on, have relations to the diaphragm. Costodiaphragmatic recess of the pleura laterally in here. Very important. Number two is the 12th rib, which is here covered in this area, and from it is jumping the subcostal nerve and vessels. So this is the kidney, posterior diaphragm, 12th rib. Then the psoas major muscle. This is the psoas major muscle here medially, and lateral to it is the quadratus lumborum muscle. At the end, we are having here is the transversus abdominis muscle. So from mediolaterally, we are having this psoas major. We are on quadratus lumborum, and here is the transversus abdominis. This is together with, as we mentioned before, 12 subcostal thoracic rib, the nerve, together with the vessels, really. Iliohypogastric and ilioinguinal nerve, iliohypogastric and ilioinguinal nerve, all running from above downwards into downwards and laterally. Okay. Coming to the left kidney to have the same system of description. Again, this is the same diagram you saw there. This is the transverse colon, descending colon, ascending colon, right flexure and left flexure. Here is the pancreas. Here is the upper pole of the kidney, the suprarenal gland, and here is the spleen. And those are covered by the stomach. You know, this is the lesser, posterior surface of the stomach, as you know, it is the lesser sac and of our abdomen. It is freely, it is a two-layered visceral peritoneum just in between. It is not stuck to it, but it is plain between the stomach and the kidney. The suprarenal gland, if we are to talk about them, there is the suprarenal gland in here. So, and the stomach, posterior wall of the stomach, the pancreas in here, then the left colic flexure having a part anterior relation to the kidney, and the coils of the jejunum, in here. So it is related to a very important structure, the spleen, okay, the pancreas, left colic flexure, and the coils of the small intestine. Let us look at this diagram again. This is the suprarenal gland, present in shape. We have the stomach in here. Posteriorly, there is a plane between it here. Suprarenal it is stuck with the gerota fascia to the upper pole. There is no plane between it and the kidney. But here there is a plane between the stomach and the anterior surface of the left kidney. Here is the pancreas going to the spleen in here. Okay, and we are having the colon, left colonic flexure, and then ultimately we have coils of the small intestine like In the right kidney, you are having a still close to the inferior wall of the small intestine, mostly to the ileal or but here mostly it is jejunal loops. Okay, so some of those structures are in intimate stuck to the gland, like the suprarenal, but like the stomach, there is some plane in that space. Relations posteriorly like the right kidney, more or less, the same structures. Here is the vertebral column, this is the vertebral column, and this is the left kidney. You know, we are making use of the shape of the kidney and describing other objects, and we are saying sometimes kidney-shaped bowel or kidney-shaped organ or something like that, you know. So it is situated on posterior, it's situated on what? The left kidney. Situated again into the diaphragm, the left costophrenic angle, because sometimes during surgery on the left kidney or even on the right kidney, we might cause for the patient some sort of pneumothorax if we injure the parietal pleura. This is one of the things we know this anatomical entity. If we don't know, we might damage. Our patient could have pneumothorax, and you know, we had to know that. So the diaphragm in here, the costophrenic recess, it's the costodiaphragmatic recess of the pleura, and the 11th, we are having here two ribs superior, 11th and the 12th rib. Coming underneath the or posterior to the 12th rib is the subcostal nerve. Subcostal nerve. We are having the iliohypogastric and coming to the ilioinguinal nerve. Those are the same nerves on the other. Of course, the muscles again, we are having psoas major in here, we are having quadratus lumborum in here, and we are having the transversus abdominis. It's a nice picture. Just keep it and try to recall it whenever you are going to touch it. Now, let us come to the blood supply of the kidney. Where is this blood supply? And we shall repeat it once, twice, and thrice. In physiology, we mentioned. In anatomy, whenever it comes, we shall call it every now and then. Very important. Blood supply, you know, the kidney. To start with, blood supply of the kidney, whenever the arteries are in the kidney, they are end arteries, functional end arteries. And whenever an aberrant artery from not the normal position from the aorta coming, you know, if that part of the artery is cut, that artery or segmental artery, if it is cut, that part supplied by the kidney will be necrosed. So there is no functioning collaterals in the kidney. And any branch from the renal artery being cut, whether from the main stem of the renal artery or aberrant artery, if those are cut, that part of the kidney will be infarcted. Let us come to the details of the blood supply. The renal artery, as we mentioned, arises from the aorta at the level of the second lumbar vertebra. Stop. This is very important to know. Each renal artery divides usually into five segmental arteries, five segments of the kidney will go and supply them that enter the hilum of the kidney at the level of L2 still, it will go transversely. They are distributed to the different segments or areas of the kidney. There is something called the lobar arteries. The lobar arteries to each segment arise from each segmental artery, one for each renal pyramid. You know, so one artery will go lobar to one of the each pyramid. Lobar artery is the artery going to each pyramid. Before entering the renal substance, each lobar artery gives us the those renal artery. Those are the pyramids, and this is the as we mentioned the lobar artery. A branch of it will give us in the renal columns in here before entering the substance of the renal substance. Each lobar artery will give the interlobular artery. This is the interlobular artery in between the pyramids. So three interlobular arteries, and interlobular arteries run towards they will go towards the cortex of the kidney, and in the cortex of the kidney The interlobular artery will give us the arcuate artery, more or less parallel to the base of the renal pyramid. And this arcuate artery will give us the interlobular arteries. Interlobular arteries, very important to know that. Run toward the cortex on each side of the renal pyramid. At the junction of the cortex and the medulla, the arcuate artery is here, exactly as I mentioned here. The interlobular artery is here, and this interlobular artery ultimately will give us the afferent of the glomerulus. Glomerulus being formed in here, and another artery will come out of the glomerulus called the efferent artery, and this efferent arteries, it will go around the tubules, different segments of the nephron, peritubular vessels, and ultimately there will be the venous drainage of those arteries. You know, we are having the arteriolar end, here is the venular end, then we are coming, here is the afferent artery, here is the artery coming out. This is the venous drainage coming to the interlobular vein, and the interlobular vein will come, you know, the other way around. The arcuate vein, the interlobular vein, then the interlobar, then ultimately it will give the to the renal vein. Both renal veins are draining into the inferior vena cava. By the way, the drainage of the venous drainage of the kidney is ample, it's rich really. And if we cut one or two of the veins, it will be replaced by others, not like the arteries at all. But they are very fragile and very important. As we mentioned before, the left renal vein is longer than the right renal vein, and that's why one of the causes to select uh, harvesting a kidney from a donor, we prefer usually to take the left kidney because of the longer renal vein. It is easy access and easy we could manipulate in a more or less easier way from the surgical point of view. Let us talk about some clinical hints. About the renal mobility, I think we mentioned some of this before. And as we mentioned, the kidney is a retroperitoneal structure maintained intra-abdominal in retroperitoneal status, maintained there by intra-abdominal pressure itself, the pressure itself keeping it in position held by the perirenal fat and the renal fascia. And as we mentioned, it could move a little bit 1 inch above during deep inspiration. Viral kidney right at a slightly lower pole, and clinically we can feel the lower pole of the kidney but in a thin patient or in a child or something like that, on a deep breath, yes, you might touch the kidney, the lower pole of the kidney. As we mentioned, there is a compartment, separate compartment for the suprarenal gland, just outside the Girota fascia. Okay. Concerning renal trauma, the kidney could be traumatized either by blunt trauma or penetrating trauma, as any organ. And the kidney, as we has mentioned, it is well protected by the strong, bulky muscles and the bone in the midline. But if a trauma in the line, being the patient exposed to this trauma, the kidney could be crushed against the vertebral column. Depending on the severity of the blow, there could be the injury could be just mild bruises. We could say subcapsular. This is the fibrous subcapsular hematoma. Or this hematoma could be given tearing of the capsule and some blood is coming out. There is grade, organ scaling system, we are calling this. Then tearing the capsule and the medulla or the substance of the giving more blood. In this trauma, there is no hematuria, no blood in the urine. But in this trauma, there will be a lot of things coming out of the urine, a lot of blood, some blood, relatively, I mean. But still here, if blood is coming and your patient is stable, the golden rule for the renal trauma is the conservative management because being protected because being affected by the intra-abdominal pressure, because retroperitoneum not opened yet. If it is opened, it could be intraperitoneal hemorrhage. Then number four, you could have shattered kidney in pieces. But still, if your patient is stable and stabilized and the retroperitoneum is intact and the patient is stable, blood pressure, pulse, temperature, yeah, so some change in clinical judgment by the senior surgeons, still we can conserve those patients. But sometimes patient is in shock because about 1/4 of our cardiac output is going to the kidneys at one time. So if the patient is in shock or unstable, straightforward to operation room and operate on them. But mostly we might need to do some sort of total nephrectomy or partial nephrectomy because we are to save the life of the patient. Sometimes we are having the acceleration, deceleration. Acceleration is what is meant by that. Acceleration means that as if you are accelerating or the moving of an object forwards in a more progressive way, accelerating, or deceleration just stopping or stop the movement of the organ, continuous movement of the organ or stopping this is what is meant by acceleration and deceleration. And if we are looking about the kidney near, this is the right kidney attached to the renal vein, to the renal artery and the ureter in here. Renal vein and renal artery is still playing a role in fixing the kidney. So, but the kidney in other sides are mobile a little bit, mobile compared to the mobility to the big structures attached. So if a patient is running or is in a car and not seat belted, and this patient is having a trauma, if the patient is accelerating like running, and all of a sudden fell down or something stopped him, stopping the patient, the kidney will not stop, but it will keep moving because there is a fixed stem for it in the artery and in the renal vein. And on that basis, if this is moving forwards or wherever the movement or the other way around, there will be sometimes sort of avulsion of the renal pedicle, avulsion of the renal artery, avulsion of the renal vein. And this status, very serious status, the patient could perfuse like hell. Patient is bleeding from the aorta or bleeding from the vena cava, and this is a state of emergency surgery to save the life of the. But here we are just to come back. The golden rule for a trauma of the patient of trauma to the kidney is conservative, whereas peritoneum not open, whereas hematoma is not progressing or increasing. Added, our patient is stable clinically, and this patient had to be observed in a hospital. This is a very important issue in our management for kidney trauma. And now we know why we are doing the conservative management, because kidney is well protected. Kidney is not. It depends on, of course, on the type of injury we are having here. Retroperitoneum in place, peritoneum keeping it in place, especially if the kidney capsules are well intact, and this being in contact and peritoneum is intact, we are as if we are treating it by as if tamponading. We are doing some sort of pressure on the kidney, stopping the bleeding. And it's a golden rule in any bleeding anywhere, even in our fingers. If we tamponade it, if we put some pressure in it, it will stop. And here it will stop. It depends on the patient and the clinical status. Clinical evaluation is very important. Another point in the kidney tumors and the metastasis, we have the renal vein. Adenocarcinoma is one of the tumors that might obstruct the renal vein. So a gentleman or an elderly presented with acute left-sided or right-sided even, because those tumors could invade to the and they block the gonadal vein or the spermatic vein, okay, in male side, or in the female side, the gonadal vein. And if you are having an acute left varicocele, think of a tumor obstructing the upper part, the drainage system of the renal vein. The renal, as we know, the renal pain could be dull aching pain because of the stretching of the capsules, or it could run along the distribution of the 12th nerve either anteriorly or to the flank. So the radiation of the renal vein, of the renal vein, is either on the distribution of the subcostal nerve to the flank and to the anterior abdominal wall. But make sure ureteric vein is a little bit different. Ureteric vein will radiate from the loin to the groin, from above the loin, the renal angle, down from the kidney, down to the groin, medial aspect of the thigh, or lateral aspect of the scrotum or labia majora, as known. For kidney transplant is good, important to have a look on it. Yes, details are not, we are not asked now to know, but it's good to add in your scope. But from the anatomical point of view, you think this is kidney transplanted in which part of our body? Let us look at this way. This is the common iliac artery. This is the aorta. Okay, and this is the common iliac artery up to here. This is the inferior vena cava, of course, sorry. Inferior vena cava, and this is the external femoral vein and the external iliac vein, and this is the internal iliac vein, the blue one. And this is the aorta being divided into the common iliac, right common iliac, and left common iliac. You know, this kidney is anastomosed. This kidney is in the right iliac fossa. This kidney is in the right iliac fossa. And this is the internal iliac artery. And this is the renal vein, anastomosed to external iliac vein. Okay? And what is anastomosed? The end of this vein to the side of this external iliac artery. So there is anastomosis end to side of the external iliac artery. The internal iliac artery here is being anastomosed here to this is the renal artery. Okay, renal artery. End to end. But sometimes we could have this renal artery to the side of the external iliac artery. Still we can do that, of course. But make sure look at this picture really. How does it look? How can you know on this is the left kidney in the right iliac fossa. Usually we transplanted the kidney, the left kidney here, and the donor will be transplanted in the right iliac fossa of the recipient, of the diseased patient, of the patient with renal failure. And here the structures of this left kidney, if the donor, we are having, as we mentioned, and renal vein anterior, renal artery in the middle, and the renal pelvis is the most posterior one. Here we are taking the kidney, the left kidney, say, and just rotate it the other way around. The anterior surface will be, this anterior surface is the posterior surface of that kidney. You see here, the anterior surface of this kidney, if we are inverted the other way around, anteroposteriorly, the anterior surface of this kidney, it was posterior in the donor side. And now the structures will be the renal vein anterior, the renal vein more or less will be anteriorly looking, so as not to be obstructed. And the middle, the artery in the middle is still, and the renal vein. This is just posteriorly, just to have an idea about it. We mentioned that is kidney transplant is the more or less the ideal treatment for patients with renal failure, non-functioning kidneys really. And we like to take the left kidney rather than the right kidney because of the longer renal vein. This is as simple as it. Here in Gaza, I think already we're having a good number of kidney transplant done already, and mostly a good number done laparoscopically and some of them are done by open surgery in the retroperitoneal space. So again, this kidney, when being transplanted, it will be put in the right iliac fossa in the retroperitoneal space. We are elevating the whole retroperitoneum going medially and bringing the kidney, exposing those external iliac vessel and internal iliac vessels, both artery and vein. And just this anastomosis we have explained in a nice and good way, just to have a look on how things. So anatomically, this anterior new kidney, anterior surface, it was the posterior surface in there. And this is the medial surface, this is the lateral surface, this is the upper pool, this is the left pool. This is very short about the kidney transplant. Thanks a lot for this presentation, and I hope you will review and ask me whatever you like and whenever feasible to you. Good luck.